Good afternoon, everybody. I know it's that time of the day when you actually don't want to sit and listen to lectures. But I'll try and my best to make it as interesting as possible. My name is Dr. Prabhu Vinayagam. I was also the managing director of JCI in Singapore. A lot of hospitals in India became JCI during my tenure. So I understand quality, I understand accreditation, and I understand what we are talking about here. So why am I talking about tech optimization? Is technology an integral part of healthcare in India today? Let's go and find out what happens. So in my hospital that I manage, my quality team comes and tells me that I have improved healthcare quality by 19% this year. So I ask them the question, what is healthcare quality? The answer I get is, I'm not entirely sure. Then how do you measure it? Honestly, I wasn't expecting a lot of questions. Right? So this is what quality is all about today. And the reason why I'm telling you is I have worked in hospitals across the Asia Pacific, and a lot of hospitals are in the same boat. It's not that I'm, belittling hospitals in India. I'm talking about it's a global issue. It's not an Indian issue. Now, what about the history of technology in healthcare? Manometer was invented in 1661, but it got used for measuring blood pressure in 1901. That is 240 years after an invention of a technology. A thermometer, the modern thermometer, which is the mercury thermometer, was invented in 1714 by Fahrenheit. But it is used for measuring body temperature in healthcare in 1866. That is 152 years after its invention. Ultrasound was invented in 1860, but used in healthcare in 1960. That's about 100 years. Healthcare is always the last to adopt technology. And I wonder why. Why does it take a long time for hospitals to adopt newer technologies? And then you come out with an answer called, it is the cost. But let's talk about how cost and efficiencies help. When you go and sit in the boardroom, there is an elephant in the boardroom. We discuss cost, we discuss growth, we discuss financials, we discuss bottom lines. But there are two elephants in the boardroom. One is patient safety, and other is staff engagement. And that's where the clowns come in. Right? Patient safety. When I look into the data of my hospital, I am given to understand that I have 3 medication errors this month. Trust me, when I go and visit hospitals in Singapore or in other countries globally, a 300 to 400 bedded hospitals, if they are not getting a medication error data per month, near misses included, of anything less than 500 to 600 errors per month, then there is a big issue. If you're reporting 3 medication errors per month, then there are only 2 reasons for it. 1, if there is gross underreporting, or 2, there is somebody fudging up the data. Right? And we try to brush it under the carpet. Patient safety is an integral part, and it has to be part of the boardroom discussions. And the second is staff engagement. That also has to be a boardroom discussion. But in all our boardrooms, except these 2, we discuss everything. Right? Cost, growth, financials, bottom lines, and that's the only thing we discuss. That is important. I'm not saying that is not important. But if these 2 function well, all the other 4 will be taken care of. Right? Now look at technology, how it is being adopted in some of the other countries. You see these top lines. This is the data from 2006 and then from 2020. How the implementation of EMR or EHR happens in hospitals. Look at Switzerland, New Zealand, from 92% in 2006, 100% in 2020. England, from 89% to 99%. Right? Similarly, look at every country, how they have been able to adopt technology in implementation of EMR from 2006 to 2010. There is one small figure. Do you find it the last? Guess which country it is. That's 0% to 5%, and that's India. We are nowhere close to adopting technology in our country, and that is a problem, a big problem. Right? And the reason for that is we do not have diversity. We do not want to put in the boardroom in diversity. And what I mean by diversity is, and I was watching in the last 3 sessions today, we don't seem to be finding any lady in this group. There's not a single woman in the last 3 sessions that I saw. All women. And why are there not ladies there? So that's one diversity. The second diversity is they're all policymakers. We're all policymakers and senior professionals who sit here. There's not a single person who is actually implementing on the field to tell about what the challenges they face in implementation, in quality. Right? And you will understand the problems that the quality team goes through. I find two people most scared in the hospital. Most scared. One is the quality team and the second is the infection control nurse. You ask them anything and they will run away. Any question. And they're afraid. If your quality and infection control team are going to be afraid, you're not performing. Right? Now, why does this adoption of technology happen? What is the problem? And the biggest problem is we physicians. We doctors are the problem. Right? Physicians and clinical teams hate the IT tools. When asked by medical economics, 36% suggested there are documentation issues. 35% reported a lack of user-friendliness. So why does this happen? In my own consultation to my own very good friend, when I go, and he has got an EMR system right on his desk, but he's still pulling out a paper and writing his prescription on the paper. And I ask him, why do you do that? Because he's a friend of mine, so I can talk to him. Why do you do that when there is a system? He gave me 20 excuses of why he can't do it on the system. It takes time. No, I'm not used to the computers. No, there are a lot of things that comes into perspective. So why clinical staff hates patient? The patient is sitting there and he says, okay, just a few more items to add to your EHR. I appreciate your patience, and the patient has already become a skeleton. And that much time it takes for him to enter into the EHR. Right? So information technology solution, there are some implementation hurdles. And those hurdles are high costs, common implementation hurdles, excessive documentation, and underdeveloped UX. And that means that because the hospitals have gone per one system over a period of time, your integration becomes difficult. And you're not able to take out the data that is necessary for you to make decisions. And if you're not able to take data which is going to make decisions, that data is useless. Right? So we get into jugaad. We love jugaad in healthcare. And that jugaad is, as the cartoon very clearly says, the patient in the next bed is highly infectious. Thank God for these curtains. As if curtains are going to save the infections. Right? And that's the kind of jugaad we end up doing with. Now, innovation, adoption in healthcare, this is what happens. The moment you put in a technology to be adopted in the healthcare segment, there are some early skeptics which says it won't work. And then there are some data guardians which says, yes, I would like to have technology, but no. Then there are some early unconvinced majority which says it's just a gadget. And there are late boycotters. The moment one problem happens, they say, I know it won't work. And then finally, non-forgiving, the minor people who are there, who say it ended up like any of the 90% of innovation which came up. So technology falls through. So we are not able to put down our technology, ensure its sustainability to achieve the results that we wanted to achieve, and therefore you get the results that you want. So what we need is a patient-centered system. A patient-centered system should include engagement, which means that you have both employee engagement and patient engagement. A seamless service, that means anybody who is operating it does not have any problems while operations. A culture that the organization should have. A transparency. A transparency is something that, again, I kept on talking during my JCI times that why transparency is important. But I find most hospitals not transparent at all. They don't want to discuss the problem. Brushing it under the carpet. Right? And a complete IT integration. What I mean by IT integration, and every hospital that I discuss with, they say that we want to have our own service. We don't want to put our data on the cloud. Right? And the only question that comes to mind is why? Because no, the confidentiality will not be, will be lost, though therefore I want to put it in my own service. Your entire bank account is in clouds. Your money is gone if that is not secure at all. Right? Why do you want to invest on huge servers to maintain your data integrity in your hospital? Through culture, clinical analytics, and evidence-based practice and adoption, there are improved outcomes and lowering costs. Clinical analytics play a pivotal role in scalable, sustainable quality improvement. Data is a vital component of patient safety, but data without an above-mentioned culture that I discussed about is useless. Okay? So once Dr. Wood said that the word that best describes a culture of safety is the civility. And in this civility, that no one is hesitant to voice a concern about a patient. Skilled caregivers playing by the rules feel safe to discuss and learn from errors. Concerns raised by frontline caregivers are taken seriously. This is the most important. If you're not taking the concerns of your frontline caregivers, like your nurses or people who manage patient directly, and you're not listening to them, then that culture is not civility. And action is taken, feedback is reliably provided, changes are visible for staff and for patients. So whatever actions you take, the change has to be visibly seen by the staff and its patients. There are enough evidence available. I'll not go into the details of what evidence is available. Each of the evidence very categorically states that by using technology, you are saving a lot of lives. Huge lives. Your performance of the hospital does not depend on, on cost alone, on performance of P&L alone. It depends on how well you manage patients. In India, healthcare is still a word-by-mouth publicity. When a patient gets well, he goes and tells another patient. That's how it works. It still works like that. Any kind of advertising or branding is not going to help if a patient comes in and goes back unhappy. And that's the only way we can improve our healthcare infrastructure. What are the changing dynamics? There is a rapid innovation in technology, and we are influencing the future of EMR. Artificial intelligence and virtual assistants like Alexa and Siri are becoming more accessible and powerful and will appear in health IT fields in a big way. Virtual assistants are coming online to help those physician burdens when they are not able to do their own typing themselves. The virtual assistant can do that for them. For patients, a big development is expanding online or smartphone access to your health information and the ability to combine information from different providers and update automatically. So technology is changing. Blockchain is coming. Blockchain uses cryptography to secure EHR data and makes it available only to those with access to it. Blockchain can validate clinical trials and claims. They track medicine distribution. They authenticate prescriptions and prevent insurance frauds. Their smart contracts can use to take action based on predetermined results. Reducing human involvement enhances errors, ensures security, scalability, and confidentiality. So these are all the technology which is available, which is coming in. Real-time data analytics. That is the future. If you are able to analyze your data real-time, then you're able to take actions immediately. And that will prevent a lot of issues that you're facing. COVID has helped us to push the clinical care teams to digitize. We have digitized a lot over the last 1.5 years. But we are still at the tip of the iceberg. There's a huge amount of work which needs to go into healthcare for digitization. New tech like blockchain ensures data security. An increased focus on standardization. Clinical care teams will see more Internet of Things and AI usage. 5G networks and their increased device loads. And wearable will boost patient health engagement. And therefore, the role of health IT is very, very important. Right? Health IT is integral to healthcare in the future. So what happens when you have a quality team? This is the kind of discussion that happens. I get the KPI reports by the end of the month only. Only nursing staff is reporting incidents. Our PSI is high on paper, but Google reviews are negative. I wish we were able to track all our processes online. And our clinical staff is overburdened due to weekly report updates. Right? And therefore, it takes out time on actual patient care. So it's important to ensure that you use integrated system which is going to throw out data and makes your life easier. Right? So there are enough and more material available. This is a software which helps you to do a QMS, which is the quality management system. And this has real-time analytics, is interoperable, is multi-device accessibility, and easy HIS integration. The solutions offered are quality management, process management, patient satisfaction management, complaint management, risk management, quality of care management, document management, and KPI data management, and much more. So these kind of software help your quality team to ensure that they're able to give you the right data that is required for you to take actions and provide solutions immediately. Right? What are the statistics tell us because of using these data? It reduces 95% of paperwork. It cannot reduce 100% of paperwork in India because there is a legal requirement of maintaining some paper documentation by every. But then the government itself is going through a EMR system, and they're developing a EMR system which is going to be in all government hospitals. And once that happens, you don't need that paper system also. It increases the reporting of medical errors by 34%. It reduces cost by 50% which is the cost of poor quality. Increases 100% staff engagement. It increases 90% of audit targets and more than 50% of proactive risk mitigation. More importantly, there are 57% increase in satisfied patients. And that is what you want. That's your end point that you're looking at. Right? So in conclusion, a constant ongoing commitment to safety from acquisition to implementation and maintenance is needed to achieve a safer and a more effective healthcare. And the only way you can do that is an integrated IT system in your hospital, which will help you, give you the data that is necessary. But let's not take the IT system so far that we start using these health informatics. Well, it's about EMRs, EHRs, PHRs, PAS, RIS, PMS, PACS, FHR, SNOMED, AI, and BI for HIs and IST. You know, that the only answer you'll get is probably, sounds more like chaos, chronic habitual acronym, overuse syndrome. Yeah, with that, I conclude my thank you for listening to me. Thank you very much.